going to share with you. I see this as an ongoing kind of discovery of what all of us have within our domain that we could share together for a great outcome and keeping people independent in their own home, using some virtual technology and some robotics possibly. I wish they could experience that as well. But I'm going to turn it over to Kim for now to kind of introduce what we're going to share with you, and then we're really hoping the primary part of the discussion will be an exchange of questions and future discussions.
Sounds
Thank
good.
you. Great. So this is Kim again, and I do head up the policy and planning team, and I also am really lucky to be able to work with federal and state legislative issues. And so we get a lot of data here in the department, so we think it's pretty important to spell out that the data we're about to present to you comes from looking at it at a specific angle. And the angle where we really started did come from questions we were getting at the federal and state level about what is the impact of services that are provided to older Iowans with federal and state funding. So the team has been compiling a lot of data for quite a few years, and they're really starting to dig deep and analyze that data. So what we wanted was a snapshot. We wanted to pull some of this data and take a look at, are we achieving the aims of the Older Americans Act? And so that's really the question that we started from. And when we look at the aims of the Older Americans Act, we can see that the Older Americans Act emphasizes that older Americans are entitled to autonomy, independence, and community-based options. So we wanted to know who is at risk of losing that inherent dignity, that independence, and what we are supposed to be preserving under the Older Americans Act. So the data team pulled a lot of the data they've been collecting and started to look at a series of factors to determine who we're serving, who's at risk of losing independence, and whether we're reaching those individuals. So that's the context where this all started. This is the focus and the aim of these particular pieces of data that we're going to present to you today. So with that in mind, I'm going to go ahead and turn it over to Dick, who's going to walk you through the beginning portions of the presentation.
Hey, Kim, this is Mike.
Yeah.
Is it okay to interrupt with questions as we go?
We love it. Yes, please do.
Okay, so on the slide that's currently up, can you maybe elaborate just a little bit on what is meant by autonomy, independence, and community-based? Just all three of those. Just to help sort of, I know for me, to help get me level set, but just so that we're all talking the same thing with each of those three terms.
Yes, and anyone in the room who wants to jump in too, but if you look at the Older Americans Act was passed in 1965, so that's really where you start to see this language for the first time is in the passage of the Older Americans Act in the 60s. And so the emphasis there was that rather than looking to institutional-based settings, we should be trying to allow people to remain in their homes and communities as long as possible. And so the premise of the Older Americans Act is to develop a network of service providers at the local level that can assist individuals to stay in their homes and communities and to help them achieve those types of choices that would allow them to do so. And so when they say home and community-based options, when that's in the Older Americans Act, they're just talking about access to different services that can help them remain in their homes and communities and to stay independent and out of facilities. That's really the underlying premise there.
Okay. So specifically on the words autonomy, independence, and community-based, for instance, how does autonomy fit into that?
I believe you really need to look at the preamble of the Older Americans Act. It's a huge preamble with a lot of goals and objectives. But autonomy, and this is just me pulling together the different pieces in the Older Americans Act, but to me, based on my reading of the Older Americans Act, autonomy is the ability to choose. The ability to say, I would like to stay in my home and community, and I would like to choose services and supports to help me stay there. So autonomy is that ability to make a choice. It's not just presumed that an individual is going to go into facility-based care, but they have the autonomy, the ability to make that decision to stay in home and community-based setting.
Great. Same question for independence.
And I think independence is used in a very similar way. That ability to say, I want to stay out of a facility, I want to stay in my community, I want to make choices that work for me, that are individualized, that allow me to stay in my community.
Okay.
And those are all words that you'll see throughout the Older Americans Act.
And then, I'm sorry, Mike, and then community-based options, are those also paid options?
Yes. Yes and no. This is Donna. They can be either or combination thereof. So if in fact you think about the community-based options, the aging network particularly, and actually some of the disability are starting to look at it too, that if you have a strong support system through your faith-based community, so you have somebody from your church that mows your lawn, takes you to get groceries, comes and does your fingernails periodically, that too would be community-based options built into what does it take to support you to stay in your own home and keep that autonomy and independence as long as possible. So it really looks at what is it you as a consumer want and need, and how can we best make that work to the best outcome.
And then is there an equation that the N4As use to consider if it is, what should I say, cost effective to keep that citizen in their home compared to residential living?
You know, Joe, that's a good question, and I would say it's questionable. Oftentimes we look at a comparison to what is extended through Medicaid to provide that home and community-based support services versus non-Medicaid. But as we are looking as a department, we don't necessarily think that's the best measurement, because if you think about Medicaid and you look at that comparison, they only purchase certain kinds of services and at only unit of cost, allotment, etc. So they would not necessarily look at those in-kind services, and their care package will reflect that as part of the equation. It would not have housing costs. It wouldn't have medical costs. So we don't really look at cost effectiveness as maybe as an underlying principle periodically, but mostly we focus on that independence and right of choice.
Thank you.
And I would just add one more thing too. If you get a chance to look at the Older Americans Act, there are definitions for some things in the Older Americans Act, but there are other words and phrases that are used frequently that don't have a definition attached. And autonomy and independence are two of those. So if you're looking for something precise, you won't find it in the Older Americans Act. It's relatively small compared to some of the other federal acts that we're used to seeing, but there's a lot of flexibility in it. And so I think there's an intentional movement away sometimes from defining words like that, so you won't find any precise definitions in the Older Americans Act for autonomy or independence.
I appreciate you going through and elaborating on these, because I know that over time words like these tend to change meaning, and they take on different perceptions and interpretations over time. And so, like I said, it's really sort of trying to make sure I understand the framework here for the Older Americans Act and try to understand some of the intentions behind it.
Yes, and I do think that you'll find that with the Older Americans Act, particularly because it is written with flexibility in mind, that there have been changes in the way some of this terminology is used over the years. That's absolutely applicable to this case as well.
Sure. Okay. Thank you very much.
Yeah.
Hi. Hello, Dick. One thing before I get going, as the slide says, the Older Americans Act consumer service data collected. The stuff we're going to go through is I want you to keep in mind that we're talking about a specific set of consumers. It's not necessarily every consumer that a AAA or an AG network might be serving. We're strictly talking about consumers that receive services funded through the Older Americans Act or ACL or our state funds. And what data we're going to show you is specifically that population of consumers and those things that were funded with that money, and not necessarily everything a AAA may do. And I think it's important that we keep that in mind as we go through this presentation. And the other thing, as the Older Americans Act as you've been talking about, has these consumer definitions and data requirements. They're all driven by the requirements of the Older Americans Act and what we're doing right now. Whether it's our state money or federal money that we pass through the area agencies on aging for those home and community-based services, all those requirements are based on those requirements. And one thing thought we wanted to start with, because we're really trying to work hard with our aging network in the last couple of years, because, and I'm sure as you guys well know, what we want to do is only as good as the data that comes into the system, and it's up to those consumers to put the data in that or report to us the data, because it is self-reported. It's self-reported data based on what they report to those aging service providers, and they're the first step in as you see, the client receives a registered service. And like I said, we're going to get more detail and explain those, but just an understanding that a client receives a registered service, which requires the completion of an intake form, which is a form of data, self-reported data that they need to fill out on themselves. Then that data gets sent to the AAA of the aging network, and then that data is entered into a software system that we provide to them free of charge, which you will find rare in a lot of other states. We provide to that free of charge, and then that data gets submitted to us here at the state agency, where we collect the data, we process it, review it, do things with it like you're going to see today. This was a new concept that Kim and Chan started with today. This isn't something we've been doing for 20 years. This is an attempt to do something with the data. Typically and historically, in my experience, data collection has been something seen as it comes to us, goes to the federal government, and that's it. And the whole goal was we got to do this to get the money. And what we're trying to do is make the data more important to the users as well as the providers as well as the consumers to understand what value there is in the data that they're providing to us. And then we enter that into our state performance report. It goes to the federal government. It goes to ACLA, OA. And then we use it internally here. We provide AAAs here with information. They have their own information. And also, just I want you to understand through this whole concept, it's a learning process we're doing with the AAAs, data we're using, they have access to. This isn't anything that they don't have access to as well. We're just trying to get them up to speed with how to use it appropriately like we're trying to use it. So this is what we're calling the data chain. And it's kind of like, I like to use back in the old days when they used to have component stereo systems. I could have a great receiver, but if my speakers aren't any good, the sound's bad. If I have $100 million speakers and the receiver is bad, it's bad. If the turntable is bad. So the whole system has to work together and all the parts be really good for the whole system to be good. And that's what we're really starting to work with, the data chain and all the people involved in it so they all understand their roles, their importance, and the bottom line is we get stuff back to them. And it's not something they just feel they're doing for nothing. Any questions on the data chain before I go any further?
Right, yeah, Dick, so this is Mike. So starting at the top of the chain, and my question is really just focused there. Since the information is self-reported, are there any validation steps with that self-reported data?
Not at this point, other than validation steps within the software that might prevent some things, but it's all just self-reported.
And Mike, an important thing to note is by virtue of the language in the Older Americans Act, it requires that we provide services to anyone age 60 and over, regardless of their income, ability, etc., and that it is totally optional that they would disclose any of this information. So we have been working hard to really have our consumers understand that while we can't require it, it does help us continue to look at where should we focus services and funding. And we've made great strides, I think, in getting consumers to work with us to complete it. So that is a disconnect with our data and our system, but I think we have taken as many strides as most states and really getting to this point. I'm hearing that we're kind of ahead of the curve and starting to take the data and punch it and making sure that we're consistent in getting people to fill out the form.
Sure. No, even with self-reported data that's optional, and all that. So is still valuable data. So I'm not questioning that one bit. But I guess what I'm trying to get a sense of is how complete is it across the whole population of people making use of the act and the services and that kind of thing. I'm trying to get a sense of how representative is it of the total population.
Well, we'll get to that. That's a good question. It's an excellent question.
Because I had that question too. I'm sorry to interrupt. So you are getting to a percentage that this would represent of the people that have submitted data to you?
We'll get to that, yes.
Okay. Great, thank you.
Any other questions on this slide before I move forward?
Nope, we're good.
All right. Then we just wanted to give a little overview of the actual reporting system itself here in Iowa, because if you work with other states, there's vendor products out there, there's different types of reporting softwares that states have the choice to use. ACL doesn't require anything as far as software systems, but we have our own. We call it the Iowa Aging Information System, and it actually has two parts to it. It has the program reporting system, which is mainly the service units and the consumer data and the things related to program management itself and information. And then the other part is the money part. What are the expenditures that they spent for each of those individual services and stuff? And one thing that we have done in the last 2 years, prior to 2 years ago, each agency had their own access database, and they would enter stuff into it and send files here. We went to a web-based application 2 years ago, so now everything is web-based. It's online, it's current to whatever, when they put it in, so we feel it's a much better system in that aspect. As you were talking about validations, at least we now know they're all using the same front-end web-based application. It's reported to us quarterly, and then on the 22nd of the month following each quarter, we just have a cutoff date. I get a backup of the database, and then we do our thing. Everything is year-to-date that we report, so it's not like we compare quarters to quarters. It's just everything is year-to-date up to the end of the fiscal year. But like I said, it's just a web-based application. They have access to all the data I have access to within the front-end system as well. We're doing a lot of changes so far, getting more data to them so they can do stuff internally as well as stuff we do within the department.
So since this is web-based, do you all have any issues dealing with privacy or data protection?
No, it's a secured system, and in fact, when we kind of had that problem with the old system, but now they use our state A&A security system, so they can't even get into the system unless they get through our A&A security account system, and those accounts are controlled by the state and controlled by us and the administrator of each AAA.
Okay.
And I don't know what acronyms you're familiar with. Dick mentioned ACL, and just in case you're not familiar, ACL is the Administration for Community Living, which is housed within the United States Department of Health and Human Services, and that's the entity that has oversight of state units on aging across the United States, which includes the Iowa Department on Aging.
Great, thank you.
Mm-hmm. As I stated when I started, we really want you to leave here with an understanding that this consumer is a finite set of consumers that have limitations to it. So it's not like, as you mentioned earlier, I think it's not necessarily representative of everybody that the AAA serves, and it's important that we understand that as you look at this data. One of the things, first of all, is some terminology is the fact you're going to hear us say a lot about what's called a registered service. And those are services such as homemaker service, case management, personal care, all kinds of services that are identified that we'll get to you later, but they're called registered services. In other words, those are the only services, if received by a consumer with our federal money or state money, they need to report any data to us. And it's important to know that when you see what we're talking to you about, it's those individuals that have received one of those registered services only. And they serve a lot of people that are not getting a registered service. And when they receive one, go ahead.
Oh, I was just saying, okay.
Yeah, okay, good. I can get going, so don't be afraid to just scream in the phone and say, whoa, slow down. But what I want you to understand is, these are the data items that we receive from each registered service participant: their age, their gender, poverty status, rural status, they live alone, their activities of daily living, and we'll get, if you're worried about what that means, Shan will be into those details and later, but just these are the things you understand. And like a non-registered service, it doesn't require what we call a consumer intake form. They're just counts. They could be the same people over and over and over, but they're just counts and numbers and totals. They're not anything specific to a consumer. These are what we call those services I'm talking to you about, the registered service. From and these are how they're termed. And you may be familiar with these terms or not. I can tell you different organizations have different definitions for these terms. Our definitions are established by AOA and the ACL, so it might not be the same as home and community-based Medicaid services. It might not be the same as public health. The point is they're driven by our AOA community. So that's another issue when you start trying to go across services, is they're not always mean the same thing. You got to really understand. But those are the list of the services from adult daycare all the way down to personal care. And what we're doing is in state fiscal year 16, we've added these additional services that will be registered services. So we're going to be different than a lot of states. We're not going to have very many non-registered services in our state. We've convinced a lot of, it was hard, but we've convinced a lot of the Aging Network users and the area agencies that it's important we have this information. It's important we have the data. We need to turn it into information. But the point is it's important we have the data about a lot of these things. So we'll be having more of these type of services.
So a completely off-the-wall question. So given both columns of data topics here, are there some areas of data collection that y'all are thinking would be useful to collect but are not currently collecting?
Tons. I mean, especially when it comes to really doing outcomes, because a lot of that has to do with follow-up surveys, talking to individuals after the fact, and we haven't even gone down that road yet.
So Mike, yeah, I was going to say, this is Donna, just, you know, and I've been around forever in this system, and when we first started the data collection, really people were kicking and screaming, and it's a local AAA I administered. We had staff that, you know, it was lukewarm, to say the least. I saw them. They would go, well, if you want to fill out this form, go ahead, but you don't really have to. And what I finally made it actually a performance issue if they didn't. So our numbers went up substantially. But I think what we've really been working hard, and I think we are starting to really make believers of the AAA, because we showed them this basic presentation a month ago, maybe. A couple of weeks ago, and our Commission on Aging, they're the governor appointees that work kind of as my board of directors. That what they're finally starting to see, that you'll see by the end of the presentation, is why this data is critical and why it's worth the commitment of time and effort to start collecting that. So that's why, you know, we've started with the registered service, have collectively agreed to add those other services in that column. But Dick's right, and Shan was nodding her head too. We believe this is the beginning point, and that they will be coming back and asking for additional data, because we are trying to really focus in what is it we should be doing, what are the outcomes we want. As the AAAs look at, I know it's unique to our system, but they are having at best level funding, but increasing number of consumers, how can they get to really drive the most important aspects of service delivery at the local level? So we know we have a long ways to go. We have the list of data. The hard part's probably going to be saying, okay, let's focus in. Why do we want that? Do we want it consistently across all six AAAs in Iowa, and really working together to get to that point?
And to follow up with that, one of the reasons that we undertook this endeavor, Shan and Kim and Linda and myself and Danica, was because this data that you see that I've gone so far has been collected for years, long before my time. And we still think there's a lot of value in that data that we can be using to identify things prior to adding more burden, because we don't want the people coming back and, well, wait a minute, you don't even use what we give you now, so why do you want to add more? And we just feel it's important that we really get a handle on what can we do with the data we currently are collecting to identify a lot of things. And that's what we're really going down the road with that. And then just so you can understand the process, even though we have a web-based application, at this point, like most states, there's still the paper, the piece of paper that when a provider or someone is providing one of those registered services to the consumer, they're responsible, usually through contract terms or whatever, working with the AAA, that each consumer fills out these forms. And then when these forms are filled out, then they're sent into the AG network, and they usually have someone that transcribes that form into our software system, data entrance, and that sort of thing. I do think some of them are getting pretty good in the fact that they're starting to look at those more. We've been doing a lot of training with them. That was kind of our first focus before even doing this. We spent the last year or two, now that we went web-based, to really focus on checking the forms, getting the forms complete. As Donna said earlier, and part of our performance requirements we've been monitoring for the last year and a half is part of that completion. In other words, we expect a 90% rate of even completing the form at all, not necessarily the form itself, but we had quite a few people that weren't filling out the forms. One of the things you probably will hear is we're very comfortable that we're less than 10% missing data in about every item except income, because people just don't want to give us their income. They don't understand why we need to know it, but we're really working hard on getting that type of data to understand what's going on as far as poverty goes. But again, there's a consumer intake form, there's a nutrition screening form which has nutrition information. Again, that's dictated through the AOA and ACL. We have also a different intake form when it comes to caregivers, which is a different set of information. So it's not the same complete information data set as we would for non-caregiver situations. And I'm proud to say, and Linda's in the room, that we have now implemented our elder abuse and prevention and awareness program into our data reporting collection system starting this fiscal year, this next July 1st. So all the paper forms and things that they would come into the department on paper is now being entered at the AAA network in our system, and we alleviated a lot of paperwork and duplication of work and stuff. So we're hoping to see that move forward in other areas within the department as well. And again, these are simply just all the data items that you saw on that other slide. This is how they enter it and put it in and give it to us.
Well, I have a question about how frequently these, data collected, because, there are all sort of, data, different types, and, it could be changed dynamically sometimes. Today I have a job, tomorrow maybe I don't have. So.
It's an excellent question. The requirement is simply we have them do that once a year. They need to do it additionally when they get a service for the first time if they've never filled one out. The only requirement from anyone at this point is they do it annually, and that's our requirement. It's not even really written in rule requirement of AOA, but we've convinced them it is good to know. Now, the only difference is, I will go back, this nutrition screening form, they need to do every 6 months. And we kind of work that in with the requirement we have in the fact that they're supposed to determine they're eligible for home-delivered meals every 6 months. And since they're determined for home-delivered meals eligibility, why not they just fill out the screening again? And most of them agreed with that, and most of them are doing that. So we do get a nutrition screening every 6 months. The other forms we just get annually.
All right. Thank you. So,
I'm sorry, this is Joe. Is the forms only in English, or do you have it in other languages too, for the consumer?
They're only in English at this point.
I will tell you, Joe, that at Hawkeye Valley, they have converted theirs for the Bosnian population, and I believe one other entity has done it in Spanish. The Milestones, I think, has. But what we find, to be frankly honest, is our non-English speaking is very, very minimal in the aging population. We think it will grow probably in the next 15 years as the people age that have moved here for employment, but right now we're not having a lot of older consumers.
And illiterate? Any?
I would say if in fact that's the case, and I know there were a couple when I was there, the staff are very good to help them complete the form by just reading it to them verbally. Most of these are done one-on-one with paid staff to help them.
Thank you.
How long, on average, do y'all have any metrics on how long it takes to fill out these forms? Is it like an hour commitment every year, or is it a couple of hours? Or?
Oh, no.
No.
That's part of the problem. I think some of them are filling them out in less than 5 minutes.
Yeah.
Ah, okay.
Yeah, it's pretty basic information that they completed.
Yeah.
For the ADLs, IADLs, my guess is that the employees help them kind of ask those questions and make those determinations. The nutrition risks, they all complete themselves, except for the very homebound frail, for their home-delivered meals, Meals on Wheels folks. Then I would say staff help fill that out because they are pretty frail most of the time.
Yeah, that makes sense. Okay.
And again, it might be different in different states, but I can tell you almost 70% of our services are congregate meals. Mm-hmm. And so it's usually filled out in a congregate type setting, and they're usually done in groups, or the meal site people help them, or those type of individuals. And they're not really the frail type that would have problems filling them out.
Sure. Yeah, just looking at the design of the examples here, it's lots of check boxes. It looks like it'd just go really quick.
It does. And they all are one page. So it's not like there's 5 pages to each one.
Sounds good. Okay. Thank you.
Any questions for me before we move on?
Oh, this is good.
No, thank you.
So as Dick said, we always find it's very important to first sort of get the grounding in the data and the limitations and the possibilities of what we actually collect, and that we are really working hard on making sure that there is good quality data before we start to do any kind of review. So that's what we've been working on the last couple of years. And just this spring, we started to maybe take a new view of the data that we have. Traditionally, we've reviewed data in terms of just outputs, and so in terms of number of consumers served, or number of units provided, money spent, general demographics such as how many women were served by our services, and generally that's it. I don't think we took any other kind of look at the data beyond that. So again, as Kim said, we started getting more questions about the impact of our services. Across the board, a lot of people are focusing more on outcomes, and so to start creating some outcome measures where we are focusing on consumer need and determining whether the services that we are offering are meeting that need. So we looked at our fiscal year 14 data, which was our, we're still actually in fiscal year 15, so fiscal year 14 is our most recent complete 1 year worth of data, and started examining that data in terms of the purpose of our programs and our services. What are the needs of our current consumers? How do we assess their needs, and then are we meeting their needs? And those are questions that are ongoing. And I don't think that this initial review that we've done have fully answered those questions, but those are the questions that we are starting to ask of our data. So we started from the top, and that is of our potential population here in Iowa, how many are we reaching with our Older American Act services? So Dick ran some numbers on our non-group quarters. Non-group quarters meaning individuals who are not living in a facility. They are not living in a group home. I'm asking Dick again. I always have to verify I'm using that term. So these are people who are living in the community in Iowa. So in Iowa, the 60-plus non-group quarters, there's 598,630 estimated individuals in that population. And in fiscal year 14, we served 46,830 60-plus consumers receiving at least one registered service. And so we estimate that as an almost 8% reach into our potential population. And then you can see there we broke it down a little bit into some different types of groups. So our 60 to 64 non-group quarters, we're reaching very few of those, only about 2%. Our 65-plus non-group quarters, we're reaching about just a little over 10% of that potential population. And one of the things that we do highlight here is this waiver number. The reason we put that in the slide is actually based on other conversations, is that we have a lot of discussion around Medicaid and the impact of Medicaid. And one of the things we try to emphasize is that Medicaid recipients only represents 2.7% of our 65-plus non-group quarters population. It's a very small number of people that gets a lot of attention. And so what we're trying to say is we are reaching beyond that Medicaid population. And so that's one of the reasons we highlighted that number in this particular slide.
And the nursing home is about 5 to 5.5% in Iowa. So we really are reaching almost twice as many in the community as our institution-wise.
And then I guess they can't see the pointer anyway.
They can't.
So what difference does it make?
You can draw on here if you want.
That's okay. So the 85-plus non-group quarters, as you can see, we're doing fairly well there, reaching almost 24% of that potential population. That last row there is sort of a separate group. These are not the non-group quarters data that Dick pulled, but this was information from the American Community Survey of the 65-plus Iowans with a disability, estimating at 143,117. And I know that these are not sort of equivalent, but we did try to say, okay, of our 65-plus individuals who received a registered service, how many were reporting an impairment related to an activity of daily living or an impairment related to an instrumental activity of daily living? And you can see those numbers up there. So 20,121 indicated that they had at least one or more impairment related to an instrumental activity of daily living, which, okay, we're saying that's about 14% of that potential population. And then almost 10,000 indicated they had one or more impairment related to an IADL and an ADL. Again, that's just to give us an idea of who we're serving in terms of what our potential population is.
You know, when I look at the data on this chart, I'm going to ask a question and I hope it doesn't come across as naive as it sounds. But when I look at the 2% for the 60 to 64 non-group quarters versus the 65 to 84 non-group quarters at 7.97 and the 85 plus at 23.62%. I'm obviously seeing jumps in those different age brackets. So when it comes to those jumps, what contributes to the increase in percentage with age?
Well, my first perception, again, we haven't dug into the data that well, but remember, that non-group quarters would include anybody that's working. So there's a lot of full-time people from 60 to 64 yet still working. The retirement age is not 60 anymore like it used to be. So a lot of those 60 to 60 were full-time employed people that probably at this point maybe themselves don't need access to our services, but what we're trying to do is say they may have family members that may have need access to those services.
So, Mike, when you think about the 85 plus, what I like about this is we the Aging Network, have speculated for years that is our primary customer base. And in fact, that's proving itself to be true because, people are pretty independent. Probably they start, if we were to break that 65 to 75, we may start seeing another increase there from the 65 to 75. We're probably still relatively independent, but you'll start seeing creeping into needing support services at 75. But 85 is where it really creeps in. The other part is Iowa ranks, I think, number 2 in the nation for the percentage of older population 85 plus. So we know that we keep them healthy and alive for a long time in Iowa. So if you want to move here, come ahead.
Good luck. Only if you can make it through the winters, Mike. See, we kind of sort them out ahead of time.
When I was a child, I lived in Vermont. I think I can handle it.
Oh,
there you go.
And also, as Shan, as you'll see through her presentation, and one of the reasons we're doing what we're doing, we still feel there's a lot of potential consumers out there that need our services that we're missing. They may be getting that congregate meal from us, but they need other things that we're not getting them to, and that's what will increase those percentages.
So that was, again, that was just to give us a sense of what our current reach is. And we know that not all Iowans 60 plus have a need for our services. So we need to ask ourselves is what do we have to offer that 60 plus population? Why would they come to us for services or advocate for us? And so the answer gets back to something that Kim started us off with is that they want to remain as independent as possible. They want to stay at home. They want to be as self-reliant as possible. And so when they start having needs that put them at risk for a loss of independence and institutionalization or increased reliance on public assistance, then that's when they might start turning to us. And we want to maybe catch them at a time when their needs aren't as intense as they maybe grow older or acquire additional impairments or acquire additional risk factors where they're going to need more intense services.
Which I think, for keeping in mind of the discussions we have had together and collaboratively, that grabbing people, that's a bad term, but, kind of trying to identify them earlier to put easier interventions in place to support their independence so we slow down that heavier level of care need as they age is really, we think, where the opportunities are.
So when I look at these three sub-bullets, I immediately went back to, what would it have been, probably the second slide of the briefing, where there's the quick overview of the Older Americans Act with enlisted autonomy, independence, and community-based options. So how do these three bullets map to those three ideas of autonomy, independence, and community-based options?
I think if I can maybe just take a hit at it and then see if somebody else. But what I would tell you, Mike, is that when we have individuals make a primary contact for information about aging-related issues, these are the three things that we hear consistently. One is, I want to be able to stay by myself. I want to be able to live in my own home and do things when I want, how I want, without somebody telling me what to do. I don't want to live in a nursing home. And then the third is, and I don't want to go on Medicaid. And that is kind of we are really taking that one probably as a first time at the department to have that discussion. They'll hear me say pretty often anymore, Medicaid should be a question, not the answer, because I think a lot of times we've said that going on Medicaid helps people stay in their own home, when in fact that isn't always the most dignified decision for older individuals, and they really want to stay independent, paying their own bills. If you've not ever been familiar with going on Medicaid, if you think about the waiver, you have to have less than $2,000 assets. Your income has to be slightly above poverty. And then you have somebody that intervenes in your life every stinking day that you're living there with, what services you have, how paperwork, recognizable means of survival, and then asset recovery at the end of your life. So it really takes away a lot of choices once you get on that public assistance. And so we're really looking at that as that truly is an underlying fact of keeping that independence and choice in your life.
Okay.
And maybe the way to think about this is the flip side, is that our OA services are designed to keep people as independent as possible, to help them avoid institutionalization and help them avoid increased reliance on public assistance. And so what we're trying to look at is, of the data we collect, is there anything that might indicate to us of the consumers that we serve would put them at risk for losing their independence? Make them vulnerable to institutionalization, or make them at risk for increased reliance on public assistance? That's the kind of question we're trying to get at.
Right, and that makes sense.
This is Dick, and I just got an iPhone for the first time a week or two ago. So anyway, I just thought for kicks I'd look up autonomy, and it says it is the capacity of a rational individual to make an informed uncoerced decision.
Right.
And I think that's what we're really trying to do, because we try to identify those people at risk so that we can inform them and their family members their best options, because someone may be telling them the nursing home's the best option, the Medicaid's the best option, but there's another option out there that we feel we need to get to those individuals before anyone else does.
You know,
maybe robotics.
Yeah, that's right. Yeah.
I want me a robot.
I want me a robot.
So Donna, when you're talking just a moment ago, you know, I was making notes to myself here, you know, down to 3 bullets. I tend to put things in my own notes very simplistically. So basically what I captured was, you know, the services are addressing the needs of older Iowans at risk for these things. But flipping it around, the older population, they still want to make their own decisions, have their own house, and under their own resources.
Absolutely.
Right.
That's perfect.
It's sort of a flipped version of those 3 bullets. So is that sort of how you see it?
Absolutely. That's great.
Mike, would you repeat that once again?
Sure. So the older Iowans, they want to be able to make their own decisions, be in their own home, and make use of their own resources.
Mm-hmm.
Whether those resources are insurance or their savings account or whatever it is, right?
Absolutely.
Thank you.
So then the next thing we looked at, again, is of the data that we currently collect, without trying to create new instruments or new forms and new processes and new software to collect and tabulate, what of the data that we currently collect that might help us identify who is at risk for no longer being able to make their own decisions or no longer being as independent as they want. And so we collect income information. We feel that people who are low income are at risk. We collect living arrangement information, so individuals who are living alone are at risk for losing their independence or autonomy. We collect information related to the activities of daily living and the instrumental activities of daily living, and again, that's whether they have indicated they have an impairment related to any of those activities. And then we also do the nutrition risk assessment and get a score. So that's the data that we currently have that we think can give us some insights into our current population and their risk for potentially losing those things that they want. I got a note here. I'm just reviewing my note here. So, okay.
My ignorance, but what is FPL?
Federal poverty level. I'm sorry. So 185% of federal poverty level and 100% of federal poverty level. Those are generally cut off for certain types of public assistance programs. And if you ask me the dollar amounts, I don't have them on the top of my head right now. Sorry.
That's pretty dang low.
It's low. Yeah.
Right, and it's important because it's to understand that, because when we talk about income, we're talking about the household income, not one person's individual income. So even though that's one consumer that got a service, they report their total household income, because that's what determines federal poverty level, which is different than some Medicaid programs, which is based on the individual's income in a lot of cases.
So our assumptions were that the more risk factors that a consumer possesses, the more likely the consumer then is at risk or vulnerable to loss of independence, institutionalization, and or reliance on public assistance. The more likely they're going to be in need of an in-home service as opposed to a community-based service or a service that they could receive in the community, and that they're possibly a Medicaid service population or recipient of other public assistance. So this is sort of how we started to look at the data then. We extracted from IPERS our 2014 consumer and registered service data from IPERS. There was a total of 46,830 unduplicated 60-plus consumer records in there who received at least one registered service. from that, we looked at 34,533 unduplicated data records because, well, we removed any record that had missing income data. Maybe they had missing living arrangement information, or they didn't complete the ADL or IDL information. So we wanted to have a complete data set. So you can see we do have some records with missing data. So 34,533 was our universe. From that, then, we created these different at-risk consumer groupings. So individuals that had no risk factors was our first grouping, and then all the way to they had all risk factors. So no risk factors, meaning they were not low income. They indicated that they did not live alone, and they reported no impairment, ADL or IADL or ADL. And I'll get into more detail about what those are, and we'll have examples and delve into that. To the other extreme is that they have all of the risk factors, that they are low income, they live alone, they have reported at least one impairment related to an IADL, and they have at least one impairment related to an ADL. Now, we actually ended up with about 17 different groupings if you sort of mishmashed up these different categories and divided up that 34,533 records, but we just stuck with these 8. They had more than 2,000 individual or records in there, and we just said, well, we'll just work with these 8. Again, this is just an experiment. It was a little research project Kim gave to us to see if we could look at our data differently, and this is the approach that we took. So before I go further, do you have any questions about this?
Of these, if you total up the number of people in all 8 categories, does that represent like 80% of registered data, or 90%, or do you have a sense of?
Well,
I didn't add it up.
Well, that's a.
We can do it really quickly.
Ask that question. It's about 75%, the 34,533, or 75% of that 46,830. But remember, okay, we only took everybody that had everything. Right. When she gets to ADLs, there's actually 95% reporting of ADLs and IDLs. Like I said earlier, people don't want to report their income. So anybody that didn't report their income isn't going to be in this risk factor group.
Yeah, and your question is, of those 8, what's the total compared to the 34,000? And I don't have that for you, but I could get it.
Yeah, I'm just trying to get sort of an order of magnitude. And the next slide has the numbers for each of those groups. So we'll just go ahead and move there. And we can divide it up. And I've thought of different ways we could sort of group these things. We could. But this is just sort of where we started, and thought we'd see what we'd come up with. Okay. One other question on the categories. As I read through the list in order, 1 through 8, are these ordered? Am I looking at what y'all assess to be increasing risk?
Yeah. So, for instance, Group 1 has 0. We consider 0 risk factors. Groups 2 and 3 have 1 risk factor. So, for instance, you look at Group 2, they live alone, but there's no other what we would consider at risk, or we are for the purposes here. Groups 4 and 5 have 2 risk factors. Groups 6 and 7 have 3, and then Group 8 has all 4.
Okay.
Okay.
Well, this one is all based on the data collected. But is there any verification by really visiting these people and seeing their condition?
No. Again, it's all self-reported information. Yep. So this is how the numbers broke out for those groups. Again, our highest number was group number 4, in that, in terms of raw numbers, they are below income and they live alone, but they did not report any impairments related to activities of daily living or the instrumental activities of daily living. And I think that was a little bit of a surprise for us. that was our highest number. And so anyway, you know, and again, we're assuming that that's sort of moving at a less risk to more risk. The red dividing line you see there between 4 and 5 is, I put that in there so that you could see groups 1 through 4 do not report any impairment. Whereas 5 and above, that's where you start to see that they are reporting some type of an impairment. So that you see there that group 5 has reported that they at least have one impairment related to an instrumental activity of daily living. Okay. So, any questions about that?
Oh, thank you.
Okay. Oh, and that's telling you. Oh, Dick's telling me that's 92%. Those 8 groups represent 92% of our 34,000 something we started with.
Oh, fantastic.
Okay. So then we started to look at those, ask some different questions of those 8 groups. First, we wanted to know nutrition risk. Nutrition risk. So, what percentage we indicated of those 8 groups? What percent did we see had a high nutrition risk score? What percent answered yes to the question, I don't always have enough money to buy the food I need? How many answered yes to I take 3 or more different prescribed over-the-counter drugs a day? Now, we just selected those 2 questions. As you saw earlier on that nutrition risk screening, there's how many total questions there, Dick?
10.
There's 10 questions, and so for these purposes, we just decided we're going to look at these 2 to see, you know, what we might find from these different groups. And then also, so nutrition risk, and then we also looked at services received. So this is the chart then for the results of high nutrition risk, don't always have enough money to buy the food I need, or taking 3 or more different prescribed drugs a day. And so as you can see from that chart, those individuals with more risk factors are also more likely to have a high nutrition risk score. They're taking more medications, and they are responding yes at a higher rate of not having enough money to buy food than those in the lower risk group. I know I don't have my little pointer, so one of the things, there's a couple of things I just wanted to circle on there just so you would point out. And I'm pointing with my finger, and I know you can't see that, so. Okay, that's all right. So if you look at what I'm calling, yeah, okay, just use it. Okay, group number 2. So here you'll notice this is a little bit higher. The only risk factor for this group is that they live alone. But when we looked at the demographics of these groups, this group tends to be older than the 2 sort of cohorts next to it. So that's why you see a little bit of a blip here with their 3 or more prescribed drugs per day, and at higher nutrition risk. But you can clearly see as those risk factors come in, their nutrition risk scores are increasing. This thing you'll notice, this little decline from group 6 to 7 and 8. You'll know one of the things that you'll know when we go into services, you'll see those folks are receiving case management at a higher percentage than these other groups. And so it's likely these folks are on the Medicaid waiver, and they are receiving maybe meals or additional services through the waiver program. And so it's actually, for us, to me, this group is more at risk because they are likely not to be on the waiver because they don't have any ADLs. Any questions about this chart?
No questions, but maybe an observation. In categories 2 and 3, I was trying to figure out why category 2 was a little bit higher than 3 because it almost looks like if you're working left to right in terms of increasing risk, it almost seems like 2 and 3 should be swapped.
Yeah. Yeah. And
but looking at the data there and what's actually being represented in the category, now I understand it a little bit better.
Yeah.
That with category 2, let me make sure I've got this right. So category, actually, I'm tying myself up in knots here.
I guess I should have labeled them maybe a little bit better.
So so it looks like there's a driver there between living alone and low income.
Yeah.
There's an interplay between the two, and that in those cases that low income is maybe less of a driver, less of a risk factor than than living alone.
Yeah, yeah. I guess, and then Dick wanted to remind you that not everyone that receives a registered service completes the nutrition risk screening. That's only for folks who are receiving a home delivered meal, a congregate meal, nutrition education, or counseling. So so this is although most of our people, that's the service that they get. But again, the one blip about this is that this group is older than these two. Like we don't have that slide in with this particular presentation, but we did do sort of an age grouping for each of these categories, and this group is older. It's an older population than these two. Okay. And the only factor is that they live alone. Okay, thank you. So then we looked at the most frequently accessed services by group, and again, those. Is that? Oh, I'm sorry. I keep hearing like a feedback, so I think somebody's talking, but it's just me talking to myself. Apparently, it keeps echoing back at me. Those consumers with more risk factors are receiving more what we're calling in-home service rather than a service in the community. So, for instance, here's our congregate meal. That means they're going out into the community and getting their meal, and that drops at a pretty regular rate. Again, this is where that impairment comes in. This is your home delivered meal, where they're getting the meal in their home. Obviously, nutrition education is something that's delivered in the home, or excuse me, in the community. It's generally paired with a congregate meal. And then here's our case management number. You can see it clearly takes off as soon as the ADLs or IADLs start to get introduced or they're living alone. This is probably, again, as I said, this is our waiver population right here.
Could you give me just a brief definition for case management, just so I totally understand it?
I'm going to let Dick give you that definition for case management. He happens to have the definition right in front of him.
I used to.
Yeah.
And maybe it would be helpful, too, if we sent our taxonomy definitions to everybody, or if they could go to our website and get them. So as you're reviewing these again, you'll know how we define the different services.
Well, and I wonder, is the question how it's defined for elderly waiver, or the way we define case management within our own taxonomy?
Just the general definition.
Okay.
Well, it's usually activities where there's a much more assessment, like you talked about, not just the intake form. There's a complete, total, in-home, person-to-person, comprehensive assessment for their needs. Then they develop care plans based on those needs. Set up providers, and then they monitor those individuals. They do quarterly visits. They do things like that as a requirement for the case management in the state of Iowa. It's not necessarily the same for every, but that's how it works here. It's just more intense type of individualized care than the other service.
I think you hit on the thing I was looking for, and so there is a care plan involved with the case management. Is that correct?
That's correct, yes.
And a case manager, and Joe, then a case manager would be assigned to that consumer, too.
Oh, so there's one type of assignment. Okay.
Yeah, so if you have 5 different services, you don't have to contact each one of them. If there's an issue, you call your case manager and they coordinate that care for you.
Okay. And is that care plan shared with the family members that might be at a distance?
If that's the choice of the consumer, absolutely.
Okay. Thank you.
The consumer has to sign off on every care plan, unless there's some legal reason they have some other person caring for them. But it's truly designed to be the consumer-oriented service direction.
And it could be long-term, over years, correct?
Yep.
Yeah, right now we're averaging 3.5 to 4 years that people are in the case management program.
Thank you.
So I just want to quickly, so these services that are listed here, congregate meal, case management, home delivered meal, nutrition education, those are by far the most frequently highest number of services that we deliver. When we have to sort of separate out those numbers from our other numbers because there's so much, units and consumers compared to our other services. So that's why we have this separate slide on most frequently accessed other services. We have health promotion and disease prevention, chore, homemaker, and information and assistance is listed there. I guess in hindsight I would have removed that as that's not a registered service, but it sort of crept in there when I was looking at the data. Material aid and assisted transportation.
So just so you know, material aid is kind of a catch-all for everything that's not in a clearly defined category. So I like to tell people, when I was at the area agency, certain things would pop up that you just could not find traditional funding, didn't fit in any of the categories that have been pre-identified but were critical to keeping somebody independent. So, Joe, I'm just going to say, so if we would have decided somebody could have benefited by a monthly contract for virtual interactive families because they had long-distance caregivers, that would have been allowable to be funded under material aid.
Okay. Oh, let's increase that category there, Donna.
Okay.
And it also includes things like eyeglasses, security devices, anything that helps them stay out of their home.
Yep.
Well, and I was curious, is that then where adaptability type things would come into play in their home to keep them in their home, like such as a ramp, wheelchair ramp, bathroom facility?
Yes, for people not covered under the waiver. A lot of those are covered under the waiver, but it's kind of we encourage AAAs to use this as a funding of last resort. So if in fact it would be funded under Medicare, they need to turn that in to them, Medicaid to them, third-party insurance. But this is kind of like, okay, we still have an unmet need, nobody's paying for it, but it's critical to this individual, let's do it. I purchased mattresses and box springs, washer, dryers for incontinent people. We used it for a lot of things that we just could not find any other funding vehicle to do.
And we used to have a service taxonomy, well, we do now, called home repair and homemaker, but we were trying to reduce taxonomy, so we included those in the definitions of chore and homemaker and some of those others. So that definitely would qualify under one of those service taxonomies.
And so again, you can see with this slide is as as soon as I keep wanting to use the pointer. Right here, this would be our homemaker. This group has a need for that homemaker services, more intensive services. These folks are probably going then onto the waiver, and that's probably being paid through by Medicaid, and so we're no longer covering those services. Same thing with chore right here, but there's definite increase that as these risk factors are introduced, these are our more intensive services, and we're seeing at least a bump increase in that. One of the things that we identified is that we feel that maybe these services need to be utilized more for this population who are indicating that they are having an ADL or an IDL that are it's just not being addressed. They told us they had those things, but maybe we are not necessarily addressing those services. And that's one of the things that we identified out of this review.
So really what we're trying to do is not only take and give data feedback to the AAA, but helping them understand that that intake form could be used differently than it currently is. Right now it's a compliance document to get registered into the system, but what, like Shan is saying, but if in fact they indicated they had those needs, then that's a trigger for you to have the conversation about what else is it that we could be doing. Again, if we could start earlier in the intervention process, and with the population less at risk, we may slow down than so many people falling into that risk category.
And it's, you know, we don't have that. So this is a modified. This is a, you know, presentations we've kind of mishmashed from various other presentations, and so some slides got dropped. But the congregate meal program is the primary service through which people enter the AAA network and start to receive services, and they are completing that form and indicating whether they have an impairment or not. And what, as Donna said, we are taking a look at is how do we then get the network to start looking at those, and then starting that conversation with, okay, you've indicated this, do you need a service, or how can we address that need? One of the things that became apparent to me is that the presence of an impairment, even as soon as an impairment related to an instrumental activity of daily living, as soon as that comes in, the need for a more intensive services increases. And so what I did then is I just, you know, I dropped our 8 groups and just said, okay, I made 3 groups. No IADLs or ADLs, at least one IADL but no ADLs, and then a group that had reported both. And again, you can see as soon as the ADL comes in, the need for those in-home intensive services increases, whereas the service that's going to be delivered in the community starts to drop off.
So I'm going to ask a self-serving question. So I'll admit it from the start. So with you know, with the comment you just made about ADL, and when that kicks in, you know, when we think about how to impact people's lives, you know, I'm thinking in terms of robotics. I'm thinking in terms of, you know, smart technologies. I'm thinking in terms of telepresence. I'm thinking in terms of all sorts of things. That it seems to me that that's sort of the area maybe to focus those kinds of technology options on.
Oh, you've got people cheering right here, Mike.
I was going to ask that same question, where is the best point of emphasis, interest?
Good job, Mike. You got lots of fans in this room now.
So, I mean, I assumed based on the fact that you all are interested in assistive technology, that then what you might be more interested in is looking at some more detail on those ADL and IDL impairment information. And so what we did is we just started taking a look at that. And again, this is just a sort of a first glance at that information. We can collect and give you additional information if you're interested. These were the things that we just selected to focus on. So activities of daily living, to remind you what those are. So the question on the form is, without assistance, can you walk? Without assistance, can you bathe? Dress, get out of bed or chair, use the toilet, eat, yes or no. So those are the questions that are asked on the form. Again, this is a self-report. We had our total records for fiscal year 14 were 48,874. That first data set we were looking at was only 60 plus. This includes everybody, so we did have some people in our data set that were younger than 60, and those people got included into this look. So of those 48,874, 46,653 had information, but didn't have missing data, in other words. So of those, 10,854 indicated that they had at least one ADL impairment, so that's about 23%. And this is how many had one or more, how that's broken down. So 3,771 indicated just one impairment. And then as the scale goes down to 6, 874 indicated they had an impairment to all 6 of those.
Yeah, but that's kind of interesting that there was actually an increase between
5 and 6.
5 and 6.
Mm-hmm.
So again, that's.
I guess we're gonna have them. You're gonna have them all. I don't know.
Exactly. Sign up for everyone.
Yeah. So that's how it broke down in terms of the number of impairments. This is what they reported that they had difficulty with, and so bathing here in Iowa apparently is the thing that people have indicated that they have the most difficulty with. And then walking, and then as you can see, dress, getting out of bed, using the toilet, and eating.
Mike, you have a new robot to build.
And I just want to add, keep in mind that we know that almost the majority of these are coming, as we said, from those congregate meal sites. So these are people identifying these issues that aren't on Medicaid, that aren't,
Right.
They're getting a meal at a meal site at their noon hour during the day and going home the rest of the day.
Yeah.
But they're still identifying, I have a problem with this.
Right.
And if you think about, I mean, you know this from the homes, and I don't think I shared with you, but they actually did one of the first. Remind me of the home, Mike, the veterans. What's the right name?
A smart home?
The smart home for veterans that they designed.
Wounded Warriors?
Yeah.
The Wounded Warriors, yeah. So if you think about the bathing, I think about my grandmother stayed at home until she was 97 and had a bathtub. And so actually that was one of the determining facts that she really was struggling to stay at home, because one time she was too weak to get out of the bathtub, forgot she had Lifeline on, and was actually in the tub for 9 hours. So, that's a huge impairment. My dad has Alzheimer's. They had a tub, and we went in and adapted and put a shower in, because he just is not stable enough to step in and out of the tub. So I think the very fact people put that there, that's probably the impairment, is the lack of feeling stable enough to actually bathe and even get in and out of a shower if it's not clearly adaptable. So that's huge.
Yeah, I was curious about the bathing in particular. The others sort of pretty well understood. I didn't know if bathing was an ingress and egress kind of issue, or if it was a hygiene issue, or if it was a safety issue, like with slipping.
Yeah, and I don't know. I'd be curious. I guess what came to mind is our housing stock in Iowa. If the homes in Iowa tend to be older than maybe in other places, then those. But I know my parents' bathroom is teeny tiny, and they only have a bathtub, and my dad has difficulties getting in and out of that. So our housing stock may have something to do with that.
Right.
And it seems as though some of the advertisers, at least in the Cedar Valley area here, have been looking at your data, because we have more and more advertisements on accessible showering and bathing. So that's kind of interesting.
It is, but my grandmother said she wished she would have had one of those tubs, and we looked at it, but it was $6,000 to get retrofit, to her tub, and even that, there's still a slight step up into that retrofit tub. So, and to be honest, she hated showers. She never learned to swim. She didn't like water on her face, and she didn't want to stand in a shower that beat down on her head. She was pretty. You really never had to wonder what my grandmother was thinking.
That's great.
So next, we just did a quick demographic breakdown, and we only did for bathing and for walking, not for all of them. And there's other sort of demographic categories we could look at, but as a snapshot, we did this. So by gender, most of the folks that we're serving are female, so that's not a surprise. And then living alone, again, if the most of our people living alone are females, and so the living alone and the female, those are both high because they tend to go together. Obviously, Iowa is a pretty racially homogeneous state, so our minority population is small, particularly among our older population. And so actually, overall, all of our services, we have a 97% are non-minority for all of our services. So, here you're seeing a little bit higher bump in our minority population with it reporting at ADL. As far as the age group, you can see obviously a little bit older. They're going to have difficulties. The red signifies nothing other than it was easier to read on the slide. This is the only color I could find where you could read it, each of those different colorings. So, and this is where they live. So, Dick, I don't know if you wanted to talk about this a little bit. We can look by zip code. So this is where people who indicated that they had a difficulty related to bathing, where they lived.
So you might, if you look at the bottom tier, two-county tier across the state, that is our highest poverty, less dense population, and largest, many times the largest percentage of population. I think Osceola, however you say that up there, that county, is also very high elder population. But if you look at it, there is some correlation then to where the intensity of older people live, to where the issues are. So we did that. This is of no consequence to you other than you, Joe, maybe, but we just wanted to show what we're giving to the AAAs to help them really start to drill down so that they can see in their respective areas where they may want to focus differently.
And also, I think it's important that it's a statewide issue. There might be some pockets, but as a whole, there's areas all over the state that have issues, and it's not just one area of the state. And so a lot of times we may be having to focus of they may not have providers for these things that we want. So it's a whole different issue to look into.
So again, this is just your demographic snapshot for those who indicated they had difficulty walking. 72% are female, 60% live alone. Your age groups, again, are going to be older. And then, again, the same, this is where they're living by their report.
And again, I think we haven't looked into it, but if you're having problems walking, you're probably going to have trouble getting in and out of the bathtub.
Right.
So they go together.
Right. Yeah. So then the instrumental activities of daily living, those are things like, without assistance, can you manage money? Can you shop for personal items? Manage your medication, prepare meals, do heavy housework, light housework, use transportation, and use the telephone. And this is what we found. So roughly 46% of the people with information indicated that they had at least one impairment related to an IADL, or 21,685. And this is how that broke down. So majority, again, are only reporting one. But, there's fair spread that many of them are having multiple IADL issues. Heavy housework is obviously has the greatest number of people indicating they have difficulty with. Yeah, robot. That's right. So that would be who are doing your laundry, any kind of outside work, heavy chores around your house, transportation. And sorry.
Talking like lawn care or vacuuming and sweeping floors, that kind of thing.
Yeah. So yeah. Right, and we have a definition of that somewhere, of the difference between light housework and heavy housework. So laundry, I think, is the one they use mostly because that's, you're carrying heavy baskets and you're doing a lot of movement between your washer and dryer, that sort of thing. And then shopping for personal items and using transportation would, obviously those kind of go together. as well. If you can't use transportation, it's difficult to shop. Heavy housework, again, this is how it breaks down. 62% of those folks live alone. And again, most of them are female, our age breakdown, things like that. This is, again, where they're living. You can see it's a lot of rural counties are starting to show up with a high concentration of people having IADLs related. Obviously, this one's for heavy housework, but I know you all don't know where our rural counties are, but Polk County is the capital, so you have your surrounding areas. This is a metropolitan area. This is Dubuque. So pretty much all these counties right down here, these are all rural areas. Same with here. These are all pretty rural areas, and so you can start to see, or there's some smaller-ish cities. That you start to see some impairment starting to kick in. Transportation, again, a high percentage living alone. Most of them are female. And this is where they're living. Lastly, shopping, 60% living alone. Most of them are female. 35% are over the age of 85. And this is where they're living. And this last slide, I just put together. The Caregiving in the U.S. report just came out. One of the things is that we ask consumers, in there just to indicate, without assistance, can you do these things? But we don't follow up and say, well, do you have the assistance you need? And so we're just asking them, is it difficult for you? And so we don't have information to say, oh, yeah, it's difficult for me to manage money, but I do have somebody who's helping me. Or, yes, I have difficulty with transportation, but yes, I have someone who's helping me. So we don't collect that kind of information. And with the caregiver program, we don't ask under our caregiver form, we don't ask them what kind of assistance are they providing to the caregiver recipient. So I thought this information might be useful in terms of, this was a study that was done by the National Alliance for Caregiving and the AARP Public Policy Institute, and what they found is 59% of caregivers are helping with at least one ADL. Most common is that the transferring in and out of bed, and that 1 in 4 finds that providing that assistance is difficult. Caregivers are helping.
Why is providing that assistance difficult?
I put the report. I put the link up there to the report.
Oh, okay.
So you can, you can read that report. They go into great detail. I just sort of highlighted a couple things that seem to be related to what we were talking about today. So,
sure.
So caregivers help with 4.2% or 4.2 IADLs on average, and most common are transportation, shopping, and housework, which corresponds with our data on the issues people are identifying that they're having difficulty with. And this we don't have anywhere in our data at all, but I thought was pretty interesting, and that is that 57% of caregivers help with medical and nursing tasks, such as injections, tube feedings, catheter, and colostomy care. So they're doing some pretty heavy-duty care for their care recipients, and that is information that we don't collect in any way. So, and that's it.
Very good.
One thing I would just point out, if anyone's tracking our contact, my email address is
put an E.
Is it accurate? There's my last name, so if you just take the E out, it's okay. MURPHY.
My bad. You had demerit for me.
Oh, thank you, Kim. I just saw that.
Yeah, no problem.
One of my email numbers.
Perfect. Does anyone have any questions?
I've got a question. I appreciate being able to ask questions as we went along. That helped to keep everything clear. When I'm going to get back to the whole idea of robotics and assistive technologies. the data that y'all have here is a really good, really good resource. I'm going to put on my commercialization hat for a second and ask this question. You know, if I'm out there and I'm making products for consumers, some kind of assistive technology things, whether it's iRobot building a Roomba, or it's someone with a special kind of shower enclosure, an automatic car wash style bathing thing, or whatever it is there any way to correlate, or at least to match up in some way, that the data that y'all have here with some kind of market survey data? So it has the information from the people receiving the services contrasted with the data that providers of products are using to look at where are their disconnects in the marketplace, basically.
Or where are there opportunities?
Yeah, or opportunities. Yeah, because those disconnects would lead to opportunities.
Right, right.
I don't know any off the top of my head other than it might be if there was some marketing as far as age groups. That to me would be the closest thing, because even in marketing, they wouldn't necessarily ask those kind of ADL questions. I'm not a marketing person, but I typically marketing things is usually by age groups. You know, when you respond to some survey, this age group responds this way, and maybe you could correlate it to our age groups of these ADLs and IDLs.
You know, if you look at market data and usage data of something like a Roomba, you know, a lot of people, they'll go off and buy a Roomba or some other, whether it's iRobot or some other vendor, they'll go off and buy a carpet cleaner that roams around their floor. And a lot of folks, they'll buy it, they'll use it for the first few months, and then they'll just stop using it. It'll just get ignored, and it just stays in a corner and collects the dust that it was supposed to be picking up. And you know, and that's what happens actually with the vast majority of Roombas. Most Roomba owners that have one, they tend to not upgrade them very often. And so I'm sort of getting back to the question of, yes, it was a neat technology item to get out there and for people to use, but what adds to the sustainability of a product like that for the people here in your survey, right? So that way, if we, you know, with coming up with products, it's something that people want to continue to use, not just a one-shot thing. And I'm not looking for an answer here. It's just, I'm just trying to get a sense of that kind of thing.
You know, before I came to the Department on Aging, I worked for the Department for the Blind, and I worked on their assistive technology team. And, you know, complicated, expensive devices did not get adopted very quickly. I mean, it's just like any kind of the technologies. Some people are more, you know, they just love the gadget and they're going to take it and they're going to learn it. Especially when we worked with an older blind population, we were working with very simple tools. So, you know, they were things like, a regular teaspoon set, and all you needed to do was bend it and then show them to dip that into liquid, and that's how they would do their measuring for liquid teaspoons, things like that. So for us, the things that sort of made a big difference were really actually sort of, I don't know if you want to hear this being, you know, robotics, but it was, a lot of them were the sort of the low-tech, easy to use, especially for that older population. We found those things tended to do better than the things that had lots of options, things that had lots of bells and whistles. They got intimidated by those.
No, that actually doesn't bother me at all, and that I'm not surprised by that.
Yeah.
One of the things that we found last year with our smart home work was that there's a tremendous lack of awareness of what products already exist on the market.
Yeah, exactly.
We're not talking a lot of high-tech things. It's just it's automation, it's conveniences that people just aren't aware of. and trying to help people become aware is sort of almost step one. You know, before you even get to what are the neat whiz-bang robotic things that you can do.
Mm-hmm.
And I think we're dealing with that right now with the Aging Network, because a lot of people that are filling out these forms, we don't feel are aware of what the Aging Network has to offer to them, even though they may be getting they're at that meal site today eating a lunch with all their friends and answering these questions. They don't realize that same entity that's providing these meals could provide them these other services. And that's an education we're trying to starting to push with this information and data. And part of that would be educating the Aging Network. As we get them to use these forms more, they need to be able to tell them what are the alternatives. And so we need to educate the Aging Network on your technologies, or like you said, what's out there.
And I guess for my own personal experience, it's getting at the caregiver, because it's the caregiver that's pushing that information on to for their parent. Because I know as I've seen my parents and in-laws get older, it's me that I'm bringing in, oh, did you know you could get these magnifiers? Or, oh, did you know you could get this? Or did you try this? And they just, we're sort of, at least my own family, we're sort of passive about what they could use or do to adapt to their, whatever loss of function.
And I almost have a question to piggyback on that. So you have staff that have expertise in working with the aging, and looking at the data that you have, where do you think is the greatest ROI? So in other words, which pain point would, if it was addressed, would create the greatest ROI to promote independent living?
Well, there's a lot of ways to answer that. I think if we looked at some of the preliminary slides where that alone indicator seemed to drive the vulnerability. I think we looked at that, and then the income is the secondary piece, or maybe the primary. I'm not sure which one would come out on top, but certainly living alone as a whole is where we believe we have the biggest ROI, and that can be a variety of interventions. But then if you start looking at the ADLs, IADLs, that gives you some more indicators that bathing is a huge underlying issue. But I think even though they rank that higher, I think walking is the starting point, because if in fact you need assistance walking, it really impacts all the other ADLs, IADLs. That is your true sign of independence. It makes a difference whether you can access, if you're lucky enough to have a fixed route bus system, if you can access getting out of your home to even be independent in the network. It accesses cooking, it accesses bathing. So, I think that whole walking challenge is huge. But I still think that loneliness factor and living alone is the beast in the room to tackle first and foremost, because I would tell you that the majority, particularly of older women, will no longer feel safe living at home by themselves. And while safety in Iowa is not the same level as safety in other urbanized areas, I think safety in our terminology is more about, can I safely make decisions? Can I safely get around my home? Can I safely prepare my own meal? So I do believe that alone factor is our biggest ROI if we could figure out what might that mean to help support that.
Thanks.
And maybe I'd like to look at this from maybe a different viewpoint as well. I'm not trying to detract from applying benefits to the people that need it. And I'm just trying to look at it from a different view.
Mm-hmm.
Are y'all experiencing a decrease in the number of caregivers, a number of staff, people that can help, get these services out and work with people directly, face to face? Is that kind of thing an issue for y'all?
It is, and it will continue to be. We just, the meeting I saw in, or attended in Portland last week was actually co-sponsored by AARP. And they have done an extensive amount of work trying to pass what's called the CARE Act, and it's a little bit different approach. But what they're saying is because there's a lack of workers, because there's a lack of family support systems, they want to pass the CARE Act, which would allow hospitals to identify a caregiver to transition people home. So right now, if you think about, and we keep saying more and more, health care is actually delivered in the home by family and caregivers, not by the medical system. And if you ever have a loved one, you know, when it's time for your insurance reimbursement to be done, you are given a transition plan, you're loaded in a wheelchair, you're rolled out, you hope to goodness you've got your medication, you hope you've got food in the house, and you hope you have support systems at home. If you're fortunate enough to have that, more than likely you're a little confused already, but there's a majority of older individuals who do not have those support systems. And so AARP, through their research, is saying we need to have legal authorization for the hospital to help appoint somebody to make that happen. But that's a long answer to your question, Mike, but we are actually, Kim and I are working with a variety of state departments to tackle direct care workforce challenges because we know that's a gap. I look at my own family. Selfishly, I will be one of our consumers next year at the age of 60. I don't intend to utilize it right away, but I have no children. I have 2 stepchildren, one who is chronically mentally ill and would never be able to provide support services for me. The other one is the mother of 3 children, and she has a mom and a dad already to take care of, and then you add their spouses on, and all of a sudden, I don't think she's a nurse, but I don't think she could do it all, and I don't think that's an atypical family composition anymore.
I agree. So we're leading on to my follow-on question, and that is, what products, what services do these caregivers need to help them be better caregivers, but also to care for more people under their own umbrella? Mm-hmm. You know, it's sort of the question of how can we help the caregivers be more effective as the number of caregivers decreases and the number of people needing care increases.
Well, you know, Mike, I think we have 2 people that now that I've seen their product, you know, Joe with your virtual interactive family, I think that's one venue that can certainly help, and I think it can help that social isolation, which Joe and I've talked a little bit about. But then, and I'm not going to remember the robot's name, it's the one that Joe drove into the wall, but I did a fine job of driving. But if we think about...
give me a break.
I know, I'm never going to let you forget it, Joe. But if we think about that intervention in a home, so if in fact you've got that robotic presence no matter where you are, but that can also link you up in different locations, I think that is a great potential. And I watched the giraffe product online, and that made it a little bit more real when, you know, she was able to set up her appointment and contact the daughter to come pick her up, and just helping connect in a whole different way, but make it much more personable because you can see somebody on the other side. I think that helps a lot.
The whole world of virtual reality that we're headed to, probably a lot of opportunities there.
Yeah.
I agree. You know, the VI Families product, telepresence, robots, virtual reality, as well as augmented reality.
Mm-hmm.
Right.
You know, there are lots of neat technologies, and all I'm trying to do is ask the question of, you know, a lot of these can be focused to the person who's needing the care,
Right.
but which of these technologies and what technologies can be applied to service the needs of the people supplying the care?
Mm-hmm.
And also, as Shan kind of mentioned earlier, what makes this incomplete is even though walking is the biggest thing, we don't really know what the walking issues are to even know what kind of technology they need. And that's kind of the follow-up we need to start looking at as we try to assess. And as we move forward with this is new to us, but as, you know, maybe a year from now, because we're trying to use this as kind of the gatekeeper, and we're going to send more people out to talk with these people to find out more detail through options counseling and other programs we have, so they'll get a better handle now of what is it truly need, and maybe we'll see a trend of everybody needs the same thing, so this is where you need to focus something on.
Sure. Well, I think that whatever technology is necessary to help caregiver or the actual people, but I think for the time being the cost will be high, so it's only for the rich people, I guess.
Yeah.
So I don't know if there is any, supporting from the state or federal government to, kind of, well, there are a lot of, solicitation to develop this technology, but I don't know if there is any insurance benefit. Without those things, I think it's not going to reach that, poor people.
Yeah. Right, and I agree. But there could be a different, if you think about in Iowa, and I know in Texas too, when you have a community, and I heard somebody from Wyoming, I think, or Montana, one of those highly populated areas, but where they have many of their communities that are very small, that rural comprises 65 to 75% of the population. If you think in that concept, and you think about the robot presence, could it be a community robot presence? So, there's a way that with a ramping that it could go from home to home with some kind of, this is for you all that are much smarter than me about it, but I think if we think about how could you share that cost against multiple homes, then it maybe becomes a little bit more affordable than trying to isolate it to one individual. Or if you think about an assisted living or a group setting, even a senior housing complex, if you had that robotic presence that could go from door to door to do some of that intervention, I agree that one-on-one, you'd have to be pretty have a pretty good retirement plan probably to have that opportunity at this point. But, I just think it's up to all of us to think about how might we at least set up the opportunity to do research and maybe do it more in a group setting to make it affordable before we start looking at then how could you become more individualized.
One of the things, I don't know, I don't have a coherent whole thought on this, but I remember I started with assistive technology for the blind in 1996, and that equipment was incredibly expensive in that, your computer cost about $2,000. You needed to get speech access technology software to put on it that cost about another $2,000, and then you had to have an external speaker that cost about another $2,000. Well, that was not for poor people, and a lot of government agencies subsidized that for people who wanted to use a computer who were blind and were at work. Well, now you can pick up an iPad that has speech built into it for $300 and is more powerful than those first equipment coming out for people who are blind. And blind people love Apple products because they have accessibility built in. And I think when Apple was doing that, they weren't thinking about how can I make this particularly accessible to blind people, although there was, certain lawsuits that came up when, as things moved to the web and they were no longer accessible. But as technology, there were certain technologies that made things more usable for everyone that then benefited those people who had an impairment that wasn't there before. So I don't know how that magic happened, but there was certainly an evolution in the technology that made things more accessible to blind people that was very expensive to begin with. So I don't know. I don't know how that happened, but it happened.
Right. Yeah, we're nodding our heads over here. That's why you don't hear anything. We're not in agreement.
I could pop in with, and as a thought to add to what you just said, talking with persons that have used technology and have had some sort of subsidy or support to purchase it. Sometimes I hear folks say, that's great, I got help to buy it, but I don't have any help for the upgrades. And so I can't.
Exactly. Oh, yes. God, yeah.
Another part of the question is how to use cell phone.
Yeah, or to teach you how to use it, as they say. Exactly.
Well, this is informative.
Good. I say, go ahead, Mike, sorry.
I really appreciate the effort y'all have put into putting this together, and Donna for getting it lined up, and this has been very, very useful. Good.
Well, and hopefully it's, what we're just trying to say is that, if there's anything else, if there are certain data sets you want us to look at, as you can tell, I've got a pretty dang good team here that can tackle it and see if it's possible and what story we might be able to tell. And then, maybe at some point, if we want to try to work with Texas, I could reach out to somebody there and see if I could make any headway that way, that you could look at Texas-related data, because they collect it as well. I just don't know if they have a team that is focused on the data outcome, but we could certainly research that for you.
That would really be interesting even for me, because the population in Texas is so bilingual.
Yes.
And it also is very metro, urban. So, Mike, some of the things, as Donna was talking about, a robot going door to door, I can visualize those high-rise complexes. It's kind of an interesting thought.
Oh, I agree. I think it'd be very, very useful to start getting data across states, and since we're here in Texas, I'm particularly interested there.
Okay. Maybe we'll tackle that and see if we can't find our counterparts there to make that happen. And just a quick reminder, too, that should you go down to Donna, Texas during the winter, you would find probably 75% of the population coming from Iowa, so we already have crossover.
And I don't know. I don't know that much about the technology you're talking about, because like I said, I just got an iPhone a couple weeks ago. So. But is there any thought to, it's kind of like the carpet cleaners, where you can go to Hy-Vee and rent one for a couple hours and bring it back, to where where you might have a place where you go to rent these technologies for a period of time until you need it again.
There you go. Yeah.
And that'd be an interesting business model to explore.
Right.
It would be. And coming out of
I have that trademark.
Technology director in a school, we were a little shy always to loan out technology equipment because of the problems that we had when it came back. But that's not saying that it can't be a created model. But
I think, because I think as was mentioned earlier, a lot of this, I think, is focusing on the caregiver as well.
Right.
And that person might be the responsible person that's able to go get it, work with their family member for a while, get something done, take it back, and understand that concept.
Sure.
So we just need to be able to rent Rosie the robot.
There you go.
That's right.
It's a good marketing tool.
There's a lot of rent options to buy around your stores, I know that.
With very easy instructions.
So, Mike, is it Rosie or Ronnie?
Oh, well, either one.
All right, so we will attempt to see if we can get some Texas connections and see if we can get some data, and then we'll just keep touching base. How does that sound?
That sounds wonderful. Again, I really appreciate the effort y'all have put into this. This is really good stuff.
Yes.
I just caution you too, this is Dick again, because Donna and, we're great at what we're doing, but I just want you to be aware it's not that way in a lot of other states. Right. So if you happen to talk to other state agencies, they do this stuff, but they don't do it necessarily maybe in the way we do it and collect it. And sometimes it's just total counts of things. It's not any kind of client consumer-specific information that can be identified back to individuals.
Sure. One completely random question. Your underlying raw data, take names off of it and stuff like that. so it's not personal. Is it publicly available?
Mm-hmm. Is that on data share?
Not this detailed information, no, but
yeah.
Is there raw numbers?
Yeah, I mean,
the raw numbers are out there, but not. We could I mean, Dick, we'll get you Dick's contact information, and you can work with him.
Like I said, we provide these spreadsheets to all the AAAs with the raw data.
Yeah.
It's just whether they know how to make graphs and charts and things like this. But the raw data, we have that now.
When you want a ginormous
Donna just says the word.
Yeah, we could be
48,000 records with 120 data elements in it. Have fun.
There you go. I'm not signing up to it. Y'all, what y'all have on these slides clearly represents a lot of number crunching, a lot of analysis. It's not something done overnight.
Right. Yeah, I'm pretty excited because I've been in this network for 26 years, I think, and it's like for years we just data dumped here at the department, and then even when I came to the department, we just reported out the data dump, and for the first time, I'm excited to see what it can do, and I think with Kim and I having to do the quote-unquote lobbying for kind of who we are and where we're going as a State Department, we have some pretty firm foundation of information to share for the first time ever, I think. So I just want to say thank you again to my team as well, because they're doing great work.
And again, you probably have found out I don't have problem saying whatever I want to say, and if I'm here next time we have a call, you'll know that this wasn't an appropriate thing to say. But I think
He looks at me.
Yeah, we are being recorded.
Yeah.
Well, but I think it's I could see some value working together as if you could think of some questions that you would need asked to meet your needs that might be good for the whole. We could, just like I do now, we don't have that information, but when AOA wants to do a survey or do those things, I work with the AAAs who have that information to send out surveys and collect that information and data to maybe give you some more stuff.
Good point. Good point.
Yep, and that's, I agree, and that was actually my motivation for asking about data sets, the raw data.
Yeah. But we could work with you and then collect the results, get it back to you. You analyze it any way you want, but under the concept that these questions would be good for anybody to know.
Right.
Oh, I agree. Well, very good.
All right.
Thank you very much.
Good.
Sure
Thank you. You bet. We'll talk again soon.
Okay. Thank you.
Bye.
Thank you.
Bye to Texas.